Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands on approach to problem solving, addressing real time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Hey, George, it's Tuesday morning. Great to see you again.
Yeah, it's Tuesday. I'm in the office today. Usually I'm at home with the guitars behind me, but I got called into work, duty calls. Today we have a great guest, Dr. Aaron Bornstein. He's a private pediatrician, and his topic today is going to be why are independent practices struggling to survive today?
Aaron, welcome to the show.
Thank you for having me.
It's a pleasure. Aaron, we always start by asking people, why did you become a pediatrician?
I would say it started in sixth grade when I realized I did not have a future as a professional soccer player. So my next choice is being a physician. My father was a pediatrician. He actually brought in our practice, so I had some exposure to that. But I would say it's predominantly my experience working as a camp counselor for many years, all the way through my first summer in med school, that really inculcated my interest in working with kids. And then my experience in med school, I further reinforced that. I just enjoy the developmental aspects of pediatrics. Pediatrics is the one field where you got the greatest opportunity to really impact an entire lifespan because of our role in preventative health. And that had a lot of appeal to me.
How long did you get to work with your dad? And how did that inform your career?
So I always joke because I didn't choose pediatrics because of him, but when circumstances came around with the opportunity to join his practice, and we had a long conversation because it is a big decision whether you go into any workplace with a family work compatibly. But it was a great fit. And we worked together for about 7 years. He had worked clinically when I first started, and he stepped back and we hired another physician to do just the administrative work for a few years as we transitioned to have a new model of how we operate in the office. And now he lives happily in retirement.
It's
Did
very
you feel,
interesting because I've seen a lot of father-son operations. It's interesting because if you go with a practice that's already established, you should be able to take it to the next level.
Yeah, I think that obviously you want to make sure you don't jeopardize your own familial relationship. I think that was the most important thing to us. We train in different times and we had different experiences, and I had my own ideas about what I wanted to do coming in, and the times had changed too. So it worked out actually quite well. I think he was and his partner, who's my pediatrician, who I still work with, is one of my partners. I think it's been a good mix, and we've had to manage a lot of change over the years, some of which was my choice and some of which is not my choice.
What you find in a lot of these older practices, the way the culture is, that's the way it is. And they want you to adapt as the junior physician, where in actuality, they should change to the new times. And I think that's what kills a lot of practices. The senior level physicians, they don't change. They don't let the junior advance. He gets frustrated and then the practice falls apart.
Yeah, I think the other thing too is that for people like my father who would start their own practice, a lot of the knowledge is institutional in their own head. It is
Right.
not systematized within the practice. And it's the biggest thing that we had to do when we were looking to transition was to make sure that we have systems in place, not personnel, so to speak, to make sure that if someone was not available or something was not working, that there was some way that functioning in the office would continue appropriately. So that was a big change for us.
yeah, before you joined your dad's practice, you went to New Zealand. You were a hospitalist in New Zealand.
Yeah, so I had immediately out of residency, I worked as a hospitalist for a couple of years in Chicago. While my wife was finishing grad school, and then we went and moved to New Zealand for a year. We were undecided about where we wanted to live at that point. And the opportunity came up, so we had an amazing experience in New Zealand. It was a great experience for me coming out of hospitals because pediatricians in New Zealand are specialists. They're hospital based. You're basically all the subspecialists roll into one. So I took care of all my diabetic patients. I took care of all the seizure patients. Worked for all the kids with genetic disorders, autism, so behavioral stuff. We managed all the neonatology in the hospital, all the inpatient care. So you really got to do everything. It was a good role coming out of residency out of a hospitalist setting. It was a lot of fun to do.
So I have a bunch of questions about that.
Yeah.
Like, getting licensed, how was that? Did you have to take boards over there, or they just accepted everything you'd done here?
Yeah, so they had New Zealand had some reciprocity, so I didn't have to research to go to New Zealand. I worked through an agency based out of New Zealand that helped with getting some of the credentialing, all the other visas and everything in order. But there wasn't anything from a retraining standpoint that I was asked to do.
That's
Oh,
good.
wow. And then you were there for a year in the size of the hospital, was it a children's hospital?
Yeah, this was a very small community hospital in a small community. The main town, I was in a town called Masterton, which is on North Island, about an hour and a half north of Wellington. At the time, the town itself was about 25, 30,000. We serviced a region about 45, 50,000. I think the hospital was 60 beds or something like that. We had 4 pediatric beds. But the geography of New Zealand is isolating. We were separated from by a mountain range from Wellington to the south. This is a rural agricultural area. I was quickly informed that there were times you cannot get kids out of the hospital because of weather, which I experienced my first month. And so it was very different. We had an excellent group at the hospital. The pediatrician I worked with was amazing, incredibly bright, smart physician. My wife became pregnant and we drove by the hospital. She saw a horse that we drove by and there were horses in the front of the hospital grazing. And I was like, oh, there's a hospital. And she's like, where? I said, not building there. And she's, you're kidding me. That's where I'm building. Like, you'll be fine. Yeah, different experience.
Or yeah, something like Doc Hollywood, the movie, if you remember that movie with
Yeah.
Fox.
So just because this is very foreign to many US trained physicians. So were there just two pediatricians covering the hospital?
Yes. So there were just two of us. Um, the system's different. The primary care is all done through general physicians, family physicians in the community. And then our practice was referral based for any of the outpatients we'd be seeing. So we had our clinics there. And then obviously children came to be admitted to the hospital we cared for. There were some specialists in New Zealand, centered mostly for us in the North Island, either in Wellington or Auckland. So we had the capacity to consult with them over the phone because this was pre networked EMR systems. So we had some support there. And certainly if a kid needed a high level of care, if you needed pediatric surgery or something like that, those kids would be transported out of our community hospital into a tertiary care facility. There's only one children's hospital in New Zealand that was in Auckland.
And was the call every other night then? Because it's just the two of you?
Yeah, yeah. But it wasn't because the population was small, it wasn't busy. But the interesting part was what we saw. And we had multiple cases of meningitis. New Zealand was in the midst of MenB epidemic. In fact, New Zealand at that time had developed a MenB vaccine on their own before we had what we have here. We were part of that rollout to try to get that out to the community. So I saw a lot of osteomyelitis, which was more predominant among Polynesian population, the Maori population. So it was interesting. There were just a
Oh,
different demographic, different issues.
So what'd you
and
do when somebody went on vacation every
Uh,
day?
we did it ourselves. Yeah.
Wow.
and so I'm assuming, which is always a bad thing, that you guys delivered patients at this, not you, but there was delivery and labor service. So you might have to come in for a C-section or,
Yeah. So we did deliveries. At my first month, I had two kind of critically ill infants, one of whom we had bad weather. So I had to sit there and resuscitate for about 8 hours before the weather could clear, before we could fly that child out. So that was an interesting experience to come into my first month there. But
so you didn't have a NICU or a ventilator.
we had like a neopup. So we had, yes, we could intubate and we didn't have a ventilator per se, but we had some equipment to help sustain someone for prolonged resuscitation.
Wow, you like adventure.
Wow.
Yeah, I don't know if I could do it now. It's been so long. I came from a hospital where I was doing a lot of neonatology work as a hospitalist. So for me, it wasn't that uncomfortable at the moment, other than adapting to the change in the metric system as far as old measurements. I would get labs back and there were been units that I wasn't familiar to. So I had to do a lot of conversions in my head. That was probably the biggest challenge.
But it seems to me it would be different if you're in a hospital here where there's NICU nurses, ventilators, respiratory therapists, when you got at least 6 to 12 beds, and then all of a sudden you're out there and there's this newborn that's not well, and you don't even have it. You don't have a nurse, let alone a ventilator or an
Yeah.
art line, an umbilical line. You're it. You're the nurse, you're a respiratory therapist, you're the doctor. and you're the chief consoler because you can console yourself.
Yeah, this is probably not untrue in rural areas of our country too. When you're doing rural-based care, you have to be resourceful because you're working with limited resources. And so, at that point, it was great for me. It was certainly a great experience from a learning standpoint, from an experiential standpoint. And in New Zealand, the culture is different. The system's a little different. So some of the concerns that you have here in the United States about liability and stuff just weren't real concerns in New Zealand. That's not to say you're concerned about the safety of the child, but you had a little more leeway to do things on your own without worrying about just the liability risk.
Yeah. I once went to a meeting in Boston for pediatric emergency physicians, and there's two guys. I'll never forget them. Typical, like you would think, two guys from Montana, white, big guys. They're in the same practice. And we're talking about suturing. And I said, oh, yeah, Northern Virginia, if a kid has a beryllium border laceration, you call them plastics. And they laughed. They said, in Montana, they come off with a finger chopped off. You're not going to find the finger. You fix it. And the dad says he's learning how to use the tractor. He says, they're not going to drive for 2 hours to get their vermilion border fixed properly. But it's just part of life. And I'm like, not in Northern Virginia. You get sued, my friend. So it's a different mentality. Yeah. Now,
Communities, they're tough. They work super hard and they put up with a lot. So it's
they
just,
do a lot. They do a lot. They go to C-sections. They do NICU. They do laceration repairs, fracture care, because nobody's going to drive 2 hours for that. And the kids need the care. In some ways, I think it might be more fulfilling, but very stressful. And so the practice must have changed a lot between the time that your dad was running it, which is probably not only paper charts, but paper accounting. And now, what is the most or the biggest things in the back of your mind that you remember it then and now?
on the face of it, I think from a patient standpoint, the patients probably wouldn't see a lot of change. Our practice is actually one of the first practices in the state to go on an electronic medical record system, to the point that when they first tried to do a prescription, the state hadn't had laws yet to allow pharmacies to accept it electronically. So they had to wait on that. So when I walked into the practice, we had an EMR and we had roughly the same type of staffing ratio. We're in the same facility. I think there are a couple things that have changed the most in practice is just what we do day to day and how we do it. When I started here, we were on the early wave when it started with Prevnar vaccine. So we were still seeing some pretty invasive pneumococcal disease. I certainly remember kids coming in and needed chest tubes and pneumonias and those sorts of things. And we didn't have road attack that came out fairly early. So we dealt with a lot more same day sick care, which was the traditional bread and butter where pediatrics was. Mhm. But early on when I came, I said, this is going to change. And really, there were a couple of things I said, pediatrics is going to become three things. It's going to become preventative well care, which is what we've always done. Visit behavioral mental health care. And I said, anxiety is going to be the new ADHD. So I was very prescient on that one. And in chronic care, I think those are going to be the three mainstays of practice. And then the same day sick care is going to disappear on us to a large extent because of vaccination. I don't think I anticipated the role that urgent cares would come into play because that's come to play over time. And that's certainly bled off a lot of the same day sick kind of care that we do. It also changed it. People are willing to wait a day or two for an appointment now for that type of visit. They just go. So I think that's been a big change. And the complexity of what we're dealing with has changed. You know, the society's changed. The substance problem has changed dramatically over time. That's really impacted family structures. We have a lot more kids under care grandparents than we probably ever had when I first started. So I think that all those societal impacts has caused changes in how practices.
The financial model also changed, right? Medicaid used to be a small part of our revenue. Now it's 51% of the kids are covered under Medicaid. And some practices have 50-50, some have 60-40, some practices have 85% Medicaid.
I think that was all attributed because back in 2007 with meaningful use to get the EHR implemented in a practice, you had to have, I don't remember if it was 20%. Yeah, I think it was 20% Medicaid in order to qualify for meaningful use funds. So people tried to get more and more Medicaids. And then the district programs came about. You needed more Medicaid to get paid. And then all of a sudden, with COVID and everybody's getting onto Medicaid, all of a sudden we went from 20 to 60%. But the reimbursement did not change.
Yeah. When I first started practice, I would say our practice was somewhere in the neighborhood of 12 to 14%
Yeah.
Medicaid. During the pandemic, there were points in time we were over 50%. But the change has been somewhat gradual over time. I mean, certainly when the recession hit around 2007, 2008, we had a large number of our families due to unemployment go on Medicaid. There was Medicaid expansion that happened in the interim as well. And then things really accelerated during COVID, not just because of employment and other things, but also because there wasn't redetermination for 3 years. Anyone who was on Medicaid stayed on Medicaid over the course of 3 years. That's starting to be managed, but that's made some real significant impacts for us in terms of our revenue flow. There are other aspects. The complexity of our patients has impacted us. A change in our EHR system has had a negative impact in terms of our throughput as far as how many patients we can see in a day. So that's had an impact on us as well.
What EHR are you on?
Oh, we're currently on Epic.
And you were interviewed by the Boston Globe, and they wrote a piece on your practice, not just your practice, but what's happening to pediatric practices in Massachusetts. And basically, to sum it up, about 10 to 15% of pediatric practices are closing down. Pediatric practices that used to be male and older, the doctors are retiring and nobody's replacing them. And it's causing a shortage of access to care to everybody, the poor, the rich, the white, African, because there's no providers. In that article, you mentioned something that I found interesting, that you do 12-hour days and 30-minute well visits. Did they misquote you on that, or are you really doing that?
No, that's accurate. A 12-hour day is not all face-to-face time. There's the third shift of managing phone calls and responding to email communication. And then also, obviously, because I'm a business owner as well, managing some of the business side of things at times and administrative tasks. I generally am in the office for 10 or 11 hours. I'll go home. I may do a couple other things at home remotely. So that's pretty par for the course. There's never a day that I'm not logged in. Generally, it's got to be very unusual to not be doing something. That has been a bigger issue over the course of the pandemic, just because we're trying to struggle to make sure that we're maintaining enough revenue to keep things flowing. And there's a lot of things that we've had to pivot on administratively to keep the business alive. But that's definitely the case. 30-minute visits to some extent was already starting to come into play prior to the pandemic. And some of it has to do with workflows, so the demands of what needs to be done during a visit. The behavioral health screening modules that we use involve using iPads. That tends to slow things down for patients in rooms. And so 30 minutes is really based around the room occupancy time. My time in the room, maybe 10 to 12 minutes, but by the time the nurses do what they need to do, by the time the patients fill out the things that they need to do on the iPad and everything else, it takes about 30 minutes to,
Yeah.
you know.
Is when I read that, I said, there's just no way you can make money. Medicare pays about $90 for a 20 to 30-minute visit. And in Massachusetts, if any politicians listening, they only pay 70% of Medicare fee schedules to physicians. So you're not even getting those $90. And so if
Yeah.
you do two of those, what's that? $70 times two, it's 140 with an overhead of easy 2/3 to 70%. There's about $40 left for the physician or the clinician, which is not sustainable. $40 is not, is nurses make more than that.
There's some lines of business of Medicaid in New York that actually for 99213 reimburse at like 54. And
Yeah.
they're doing a lot.
Yeah. Yeah. And then, so this is a big problem to the sustainability of a pediatric practice anywhere in the country, right?
Yeah. Part of the reason why I started to speak up is we're in a wealthy state. We're a well-established practice. We have a lot of advantages that a lot of practices don't because of our networking and other things. And yet, if a practice like ours is threatened, any practice that has any modicum of greater challenges than us is really in big trouble. We already had 2 practices this summer in our network have to close, and there will likely be more to follow, just because once a lot of us are still functioning to some extent on federal COVID funds, whether it's PPP loans or ERC loans or HHS loans. Yeah, this is the last year you might have any carryover from that to try to figure things out. And once that runs out, if you haven't figured it out, you're cooked, right? If you can't make enough revenue per month to cover your expenses, there's nowhere to go.
Yeah. And just to level set with the audience, Mass Health is a provider of Medicaid financing for Massachusetts, right? And they only invest $3,400 a year per child, which is nothing. And an able-bodied adult who joins Medicaid, they will get $500 a year. So a tremendous discrepancy for somebody who could actually go out there and get a job and pay his own way versus a vulnerable child that obviously can't fix their economic circumstances. And that is just tearing us, not only in Massachusetts, but across the country, the lack of investment in our children. I call the politicians cowards because they haven't been able or willing to step up and fund these services appropriately. About 1.6 billion of the Massachusetts Medicaid budget is spent in children out of a total of 17 billion. So it's almost nothing. People should be ashamed of. And out of that $17 billion that they spend, only 400 million or less than 2% are spent in physician fees, labs, and radiology. We could not see any more patients, not order any more x-rays, not order any more labs, and we would not have any impact on the bottom line of the spending at the state level on the Medicaid system. Yet they want us to report BMIs. They want us to report this, report that, and decrease the cost. How can you decrease the cost when they're not spending or investing anything in our children?
You know what was very interesting? These insurance carriers, I had asked them once, I says, why do you people reimburse so well to a hospital? And the hospital cries poverty because they say they have to bill the insurance carrier more because they have to take care of the Medicaids. Dr. Bornstein, you take care of Medicaids, I take care of Medicaids. Medicaid lines of business. Herb, remember my wife when she had that pickleball injury?
Yeah.
I just got the bill from the hospital.
Oh, well.
Emergency room paid $1,680. Pharmacy $16. That was for one pill of Percocet. And radiology diagnostic $1,851. And we have a $400 copayment on this. So that pickleball injury cost $3,182, and then $400 for us paid for a sprained ankle. That's crazy. Do you see sprained ankles in your office?
All the time.
All the time. So you went in, they put you in the room. They gave some ice. They gave her a Percocet. They sent her for an x-ray. 2-3 hours later, your x-ray is negative. Stay off of it. Go to an orthopedist. This is ridiculous. And you'll get $54 from Medicaid.
Yeah. The issue, I think to some extent, and I've sat, we're networked within Mass General Brigham. So we're in a network that involves both adult care and pediatric care. The pediatrics is such a small piece of the budget globally that pediatrics gets overlooked. And then on the flip side, and when someone this in the state recognized this and other people, we're so cost effective. You're cost effective because we don't get paid, right? To some extent, there's that balance. So it's a little vicious cycle, but there is truth in that we're cost effective because you're right. I can take care of a sprained ankle in a much more cost effective manner than an emergency room can.
Wow.
And we do all the cost effective work. Every phone call we take at night is keeping a kid out of an ER, but you don't get compensated for that. You don't get paid for that type of work. And unless the system really puts the emphasis on reimbursing those who actually spare costs in the system outline and spare unnecessary testing and unnecessary medical expenses, it's an upside down kind of way of reimbursement. You're reimbursing retroactively rather than proactively, essentially.
Yes. And so a lot has changed and it's increased your overhead, right? You said your dad already had EHR when you joined the practice, but MOC keeps being expensive. CME keeps being expensive. The vaccine costs, and we'll talk a little bit more about that later, are increasing, and your staff can't live on $6.50 an hour wage anymore, right?
Oh yeah. No, our expenses in the last 3 years since the pandemic have gone up like roughly 25-ish, 30%. And that's across the board. Staffing costs, especially, have gone up dramatically because we're at a time of scarcity of staff, and it just became this race to try to keep staff, find staff, and salary structure for all that goes up. It's hard to find people. We are continually looking. Actual expenses, it just kills me to think about how much money we spend on McKesson every month just for supplies. This is where I think a Fortune 5 company, their bottom line is not hurting. And yeah, I still ask myself why it's still, the pricing has gone up so much.
And
Yes.
neither the commercial side nor the government side is giving us a cost of living or inflation index increase in our payments. They have us frozen back in some plans in 2020 contracts. And the expenses, I don't know if any of these politicians buy groceries at the grocery store, but the expenses have really gone off the roof since the Biden administration came in. And that's affecting everybody because the front desk person can't eat if you're not giving them $15, $17 an hour. They just can't eat. And everything's gone up. But I don't know where they expect us to come up with the money to pay the front desk a living wage and continue to buy supplies, but we're getting paid less. Doesn't sound like mathematically that's possible.
Yeah, no, I mean, that's the problem all of our practices are running into right now. Because we're not a restaurant where you can raise the menu prices. You're locked into your contracts with your insurers. And so our businesses are not able to adjust our pricing according to inflation or according to increased expenses accordingly. And this is why you're going to see practices closing because they just can't make it. Pediatrics is always a slim margin kind of business, right? We're making a ton of money. There's not a lot of margin there even before all of this happened. And then for something to suddenly drive up your expenses that much and drop your revenue at the same time because we weren't seeing kids as much over the course of those years because they weren't getting sick when they weren't as wearing masks and those things. Yeah, it's just a double hit. And it's something that'd be hard to recover with unless there's some change in how financing around our businesses work.
Yeah. And then we have some miracles, but yet again, it's all about how we finance healthcare in the US. So I don't know if Massachusetts is a BFC state or not. For the non BFC states, they're asking us to vaccinate kids at 6 months and then again at 8 months with a COVID vaccine that is going to cost us $200. And many parents don't want it. And logistically, it's very difficult. And then we have a new product, which I think is would be great for the health of kids, but this RSV long-term monoclonal antibody is $500 a shot. So if you have just a normal pediatrician, one FTE has about 100 newborns, if they're going to stay in business a year, half of those are commercial, 50 times 500, that's $25,000 that you're going to have to write a check for at the beginning of fall and not even know if you're going to get paid for it.
Yeah,
That's
no, that's a huge issue. Like those types of expenses, if you don't have enough revenue flow, there's not an easy way to manage that. And then you're limiting the care you can provide. And we've had to do that with some of our lab testing, for instance, because the reimbursement for the test is not actually covering the expenses for the supplies for the test. And so things that we used to be able to do in office, we can't just because we're not getting paid enough to cover the expenses. We're not looking to make money off of it, but we have to at least break neutral. And the same thing's true with what you mentioned with nurse-several, these other types of therapeutics.
Yeah. So I always say this in our coaching class, right? So I'm a little annoyed when you steal my time and don't compensate me for it. I'm a little annoyed. Okay. But maybe if I help someone, I'm okay with it. But I'm really annoyed when I paid for something $25 and you pay me back $12 2 months later, because that really means you pick it in the pocket for $12 and I'm not a chump. And that's what they're doing. The health plans are doing to pediatric practices over and over again. And that's really offensive.
Yeah. And beyond offensive, it's not smart, right? So my patient who could get a lab less expensively in my office and get a result that day and get therapy started that day, instead has to go to a commercial lab where they spend more money to get it done, maybe wait a day or two to get a result. Maybe in that interim, the kid gets worse. They go to an urgent care to get told it's the same thing.
Yeah.
It's just not an efficient way to do it. Point of care testing should be really promoted heavily in primary care because of the efficiencies of being able to make a rapid diagnosis and make appropriate treatment decisions. It's short-sighted, but having that penny wise, pound foolish when you have those types of policies in place. And I think that's what's frustrating to us. A lot of what we do are is mindful about cost. We're careful with our patients' money. We try not to, do unnecessary things. We try to keep them out of ERs, which are not a pleasant experience, which are expensive to families that can't always afford it. And we're not always allowed to do that by virtue of not being compensated to be present to do the work or by being asked to actually pay out of our own pockets to do that work. It doesn't make sense.
Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information.
My favorite test that they send to the lab is that rapid viral panel that does like 20 different viruses. That in the hospitals, they made a killing on this because if you came in for constipation, you got a rapid viral panel just in case it's COVID. $1,500 reimbursement. It cost about, I think, $400 per test kit and then whatever other stuff, but still, it's great reimbursement. Yet you cannot do that, even if you had the kit.
Listen, the most cost-effective test we do is our own physical exam and history by far.
Yeah. That
Yeah.
costs something, your salary.
Yeah.
And you mentioned this in the article, which I think is happening across the country. How has the loss of pediatricians in the community hospital ward and community hospital emergency department put in danger the health of our children?
So I think what's unique about pediatrics, and part of the reason why I started to speak up, is there is a general primary care crisis. There's not enough family physicians out there. There's not enough interns out there. But the difference is that the global system at large supports them. So these practices that struggle in those domains often will get bought up by a hospital system because they see value in those practices. Where we are in the state, there was a lot of hospital consolidation and buy up. And the groups that bought these hospitals got rid of pediatrics and OB for that matter, because they viewed them as not money-making ventures. And so suddenly we're in a part of the state where the hospitals don't have pediatricians or pediatric floors in the hospitals. And over time, the clinicians lose experience or comfort level. I feel for the emergency physicians because they've been speaking up on behalf of primary care because they're feeling the brunt of it. When we had pediatric hospitalists in the hospital or us, there was always someone there they knew could back them up or come down and take a look at the kid. They don't have that anymore. And so what happens is these kids will get brought to the nearest ER. The physician or the clinician or the PA or whoever who sees them may not be comfortable, and they just get shipped out all the time up to Boston or up to Providence. And then the family incurs costs for ambulance ride. They get to the children's hospital and they're like, okay, you're fine, go home. And it's very inefficient. So that's a negative experience for a patient, but that's just a negative experience of cost and everything. It's a more dangerous issue when you have a kid who's really sick and either gets brought to a facility that can't handle that kid and there's a delay in care because of that, or they don't recognize the kid that was sick. In the article, I used the example of an infant who had been seen at a local hospital by an ER physician. Frankly, it's a good ER physician. Like I've known this person for a while, who just didn't pick up on the fact that this infant was septic, came into our office the next morning. Clearly the kid was septic. And it wasn't simply a matter of saying, oh, you need to go to the hospital. Like I had to call it and I had to speak with the head of the group to say, listen, you can't bring this child to the nearest hospital. You have to break your EMTALA rules and drive this kid much farther to a facility that can actually care for it. And then I had to find out when that facility had bed space available and all that kind of stuff. I don't think that kind of thinking would necessarily happen at an urgent care where this kid have showed up, where they don't really know the lay of the land as far as pediatrics. And you worry that the outcome could have been very different if there was a delay of 6 or 8 hours because they had to get waylaid at another hospital. That to me is a safety issue that unfortunately isn't getting addressed. And the reason why this comes about is because the hospital systems don't see pediatrics even as a loss leader. They just see them as a loss. There's no one that's going to come in and replace our groups. There's no multi-specialty group that's going to want pediatrics. There's no hospital system that does because there's no money in it. We're budget dust and budget negative. for them.
Yeah, I've been told that by insurance guys.
And so your experience with the kid could have died from sepsis. Just I only do clinic now once a week, but I had two similar experiences. A little kid who wasn't eating well and went to the urgent care, and they told him, "Oh, he looks fine." He came in. I looked at him. His pulse ox was like 92% and tachypnic, and I couldn't hear anything in the chest. But I'm like, "This is not someone I can send home." Sent him down for a 30-mile drive because the two community hospitals in that county no longer accept pediatrics. He's had rhinovirus, but he had rhinovirus pneumonia and stayed in the hospital for 10 days. A kid could have died, or his brain could have been fried from hypoxia because the person taking care of them initially didn't know a simple fact: when the baby doesn't feed and they're under 4 or 6 months, you got a septic child until you prove otherwise. But that's not rocket science. I could teach that in 2 days. They're so burned by other stuff that they forget. And then the other child, which was just appalling to me, was a patient that was seen for urgent care consultation over the TV. And they were told they had hand, foot, and mouth disease. And then they went to the emergency room because the kid wasn't getting better. And then again, the adult ER doctor told them they had hand, foot, and mouth disease. And then they came into the clinic and he had poxes all over his face and he had severe eczema. And I said to the mom, "Does he has anything in the hands?" "No." "The buttocks?" "No." I said, "How did this start out?" "Oh, like a cold sore." So he had eczema herpeticum, and he could have lost an eye if you're not careful. And again, that's not rocket science. If you don't have sores in the mouth, you don't have sores in the hands, and there's not some in the butt, it is not hand, foot, and mouth disease. But these mistakes are being done every day because of a lack of training. And it costs the system a tremendous amount of money. That patient had 3 visits when if they had gone to a pediatrician, they would have been able to take care of it the first time around. And it's just a big problem. It's a big problem. It's really hurting our communities. You touched on the fact that we have a primary care shortage, and it's not going to get better anytime soon.
Yeah.
Right?
The shortage is here already. It's not going to happen. It is here today. I don't know if you can hire physicians. We're having the darndest time. If anybody's looking for a job, reach out to me. And the other problem is nobody wants to work full time.
Yeah. In Massachusetts, there's a report that came out last fall that just over a third of all the primary care providers, so that's family medicine, internal medicine, geriatricians, and pediatricians, is over the age of 60. And that should scare people quite a lot. And the reality is that for us in the current climate, we can't possibly offer a salary for a physician coming out of residency that would be commensurate to their debt load, or what would be an average debt load. Obviously, if you're a person who doesn't carry average debt and you're fortunate to come from a family that have means and you could afford all your education, then you can choose to do what you want irrespective. But it doesn't make a lot of sense logically that you would be able to get someone coming out and simply replacing someone with our level of training, experience, with a physician assistant who has very little exposure to what we experience in residency is risky. I always said that one of the issues with being a nurse practitioner at PA is simply what you get exposed to in training. You don't know what you don't know, and you can't see what you've never seen. And one of the things that for us, when we went to residency training, even before the new rules, was that for better or for worse, you saw a ton. I trained in Chicago. I saw a ton. I did med school in Pittsburgh. I saw a ton. And I knew I needed that, right? Because you need to be able to recognize the 1% of the uncommon things that might show up on your doorstep when you're in a community to make the right decision for that child. And I'm concerned with how difficult it is for PAs and MPs to get adequate training. Even just finding a rotation for them is very difficult. We get requests all the time. I don't think replacing physician pediatricians with that kind of workforce is going to be the best of medical care for kids.
The one thing that I learned early in my career by one of the senior guys was he told me pediatrics is as follows. Children will get better, usually despite what we do to them. Sometimes if we give them a treatment or a therapy, they may feel a little bit better. They may get better a little faster. But the true art of pediatric medicine is in a room of 100 normal kids, you should be able to see the one that's nuts. Then you're a pediatrician. That's wisdom.
I,
Bob Brown.
yeah. I remember when I first came into practice, I walked into a room, it was a 13-year-old checkup. I'd never seen this kid before. And I looked at this kid and I'm like, oh, this kid's got Putz Jaegers because he had all the freckles over his lips and everything else. And so I asked him, I said, listen, is there anyone who had a history of colon cancer in the family? And there was like, it's a relative. Said, I know I never met you before. I know your kid looks healthy, but I'm very certain your child has this genetic condition. And I think we need to get you seen by some specialists. Yeah, the funny part of it was they went to the specialist like they could put it initially, and then the endocrinologist came back. And said, oh my gosh, the testing came back positive. I'm like, yeah, 'cause this was a clinical diagnosis. But
Oh,
the important part of that was all the family members got screened, and there were several family members who had precancerous lesions, and they were screened young. Those family members probably would have gone to colon cancer at a young age prior to what the standards would have been for colonoscopy had we not made that diagnosis. The impact of you're trained to pick out that rare case matters, not just for the kids sometimes, but for the family as a whole. Is a perfect example of just, I knew it because of my training and my background, but I really don't think that a lot of people who go through an accelerated program with limited time in the hospital and seeing rare things would have picked up on it. They said, well, I was just a freckly kid.
right. And to be honest, that the PAs and the nurse practitioners, they have a role to play, but there's a reason why they don't go through medical school. That they don't want to put the effort or the money into it.
Yep.
It's a shortcut. And that's not bad. If you're gonna do a bunch of physicals and that's all you're doing, and whenever there's an abnormality, you call the internist or you call the pediatrician to come in and look at the patient. Yeah, they can do a great job. But they're not gonna stay in primary care because they're starting $100,000 and the hospitals pay them at least 80 to start to be a nurse. And the gastroenterologist and the dermatologist can afford to pay him 150 to 200 grand a year. And there's no night calls, there's no weekends to be done. Everybody's done by in the office by 4. You think they're going to stay without a pediatrician in an office making 100,000 a year when they can move over to the orthopedic surgeon and make 150 and only work 4 days a week? They're smart people too. They're going to go where the money is.
Yeah, and we have nurse practitioners who are wonderful, and one of whom has been in practice here longer than I, and they do a great job. And medicine's a team sport. You cannot function on your own. Your whole staff has to be good, right? Your front desk staff has to be excellent. Your nursing staff has to be really on key. Our nurse practitioners do everything that we do. Even the ones who are very experienced still will come to me with questions. And that just tells me that the foundation of your knowledge base comes in your training. And yes, you learn as you go along the way, but that foundation matters.
Yes. But
But
we're
why these medical students have to do all these USMLE questions and they're studying nonstop for the boards.
yeah.
So they pick up that Pittsburgh.
Yeah, but we do the same thing as pediatricians, right? I don't know, Aaron, if you manage your diabetics, but I haven't managed a diabetic in 20 years. And so when I have a diabetic patient, I call the endocrinologist and I hand them off because it's just not something I do every day. And I cannot, in good conscience, take care of that patient without a peds endocrinologist running the insulin. It's just not what I do anymore. And that I think just is the sign of a prudent and caring clinician to know the limits of your knowledge and experience. And sometimes that's these poor PAs and nurse practitioners are put in circumstances where the system forces them to go beyond what their experience and knowledge is. And we can get in real big trouble that way.
Yes.
Aaron, do you think that doing good can pay the car payments, taxes, and mortgages?
No, you can't run a business on altruism alone. Even religious organizations, churches and synagogues need money. And they're doing quote God's work, right? Yeah. No, you have to be able to afford your expenses, especially with your staff. I think when we were going through the pandemic, we had to make some difficult choices. We were really concerned about safety, among other things. So we had to make sure to do a lot of expensive things. We ventilated all of our rooms independently so that we're sharing ventilation. from room to room. We kept our staff whole. So while they were working 20 hours a week early in the pandemic, we kept them on full salary to make sure that their families weren't going to suffer. We didn't want people to lose their health insurance. During the course of the pandemic, God forbid someone got sick. We made decisions as business owners to do things to make sure that people were kept safe and kept whole. That was a choice that we made because we had that ability to do that. We don't have shareholders that were responsible too. That was a financial decision out of our own pockets. But you can't do that forever. Like you can do that for a year or two. But if you want to be able to keep a practice sustained, and for me, this is a legacy practice. My dad started it. So it's a goal of mine to keep this in the community. You have to be able to offer salaries that are competitive to attract talent, attract people, and keep people. Because functionally in medicine, a medical office is about the people inside the building, not the building. The building doesn't do the work. I thought it was a little funny when you get a hospital facility fee. I went to get stitches. I'm like, the building didn't suture my whip, but the ER physician did. Yeah, no, you need to have reimbursement to cover all that. And that's not true. That's not different than any other business.
Yeah. What is that statement that I always say, Herb? If you do good quality medicine, the money will follow. If you follow the money, you'll never do good quality medicine. I'm starting to doubt that now. If you do good quality,
Yeah.
there's no ways that you're going to get money on it.
Yeah. The demand on us would suggest that we need to double the number of patients we see, but you can't possibly do the right type of work
Correct.
in the day to do that. Or I'd go from 12-hour days to 18-hour days and I would just not be.
And there's I don't know if other physicians experience this. There's been times in my life where I've seen 50 kids in a day, either in the ER or the practice or a clinic. But if I get much over 30 patients in one day, and then I had to do it the next day and the next day, about the 15th patient, my brain is fried. I'm going through the motions. I hope I don't hurt anybody, but I'm just spent. I just can't talk one. Now, luckily, I don't have to talk about rotavirus very much anymore and the brat diet and all that. But I can only say so many times you got COVID. There's no medicine at this age. The kids do very well. If you have any problems, just come back. The pulse oximeter is normal. And then go on to the next room and say it again and go to the next room and say that. I can pull that off 2 days, see 40 kids every day. The third day, mentally, I'm spent. I'm not giving my 100% to those patients. And so we cannot make it up in volume and do good care. Aaron, this has been insightful, but somewhat unhappy conversation.
That's just my personal opinion on it. So I think that legislatures will listen to patients and constituents is what I'm learning. The lobbyists have their ear. The senator or the representative has a million things on their plate. They don't understand the nuances of everything. What they do understand is that they have 100 angry patients saying, are you going to see my kid when he's sick because my pediatrician left the community? What am I supposed to do? And I do think at some point there needs to be some greater public awareness. Patients view our practices as a public commodity, when in fact we're a private entity. And if we're going to be treated like a public commodity, then the public entity, the public structures around it have to fund it appropriately to maintain it.
Right. They have to take the risk away, right? They have to own the building. They have to eliminate malpractice. They have to buy all the vaccine serums.
Yep.
And you just get paid an amount per kid, which covers your salary, but you have no risk. But we're far from that. I think that will not likely be a model that we'll see in the US for primary care. The other thing I do warn the politicians out there, they're listening, is that there's nothing worse than making a mother angry.
Yeah.
And you're making a lot of moms angry. You might not care about me, the old white guy who's crabby and angry at this stage of my life. If a 25-year-old mom with a kid that had a bad experience because you don't pay for the pediatrician visit gets a hold of you, you're in deep trouble. That's why they call them mama bears.
Yeah. When I think about the 10,000 kids in the two practices, our network that closed in communities of color, and I think about all the discussion around equity, there should be some real alarm bells around this.
Yeah.
Where all those patients go to?
No one.
Did they go you?
No one's going to take them because mass health's like lemmings, right? When the lemmings leave one ship, they come and push the next ship over the cliff. While the practices refuse to accept these patients because they know that'll sink them. And these kids are not going to there's going to be nowhere to go except for the ERs and urgent cares. It's a real issue. The public needs to be aware of it. It's impacting all types of communities, but particularly communities that have higher rates of mass health in our state, mass health. And the world should not just be haves and have nots. There's plenty of money out there for everyone to be have some, is how I view it. It's just a matter, and you cannot take the same pool of money and just shuffle the chairs on the deck of a sinking ship. You actually need to invest money into the ship to keep it from sinking.
Oh, I like that.
There needs to be some real discussion broadly about where money is invested in medicine. Every line of medicine should be at least sustainable in and of its own right. You should not be viewing certain lines of medicine as a loss leader like that. That's just a backwards way of thinking.
Correct. For those people that think that the healthcare systems are going to start providing pediatric services, take a look at your community hospital. See if they're for not for profit. See if they have a pediatric ward. See if they have a hospital pediatrician. See if they have someone to attend to the ER when a pediatric patient comes in unstable. Many of them don't even have neonatologists on staff anymore. And they'll do the delivery because
Makes
to them, no, they lose money on deliveries. They've been losing money on deliveries for 20 years. The reason hospitals do deliveries is because the mom decides where the family goes for care. And so they want the mom to come in, just like Wegmans wants people to come in. They put the milk at the end of the corner over there. And while you're going to get the milk, you end up buying chocolates, a bottle of wine, some chips. Oh, those cut cheeses look really good. I'm going to put them in the cart. They could care less if they ever sell you the bottle of milk. They just want you to walk through the supermarket so you can load up with stuff that you're not going to need, but that's where they make their money. And the hospital does the same thing. Come deliver the baby with us. It'd be really pretty, maybe not safe, but really pretty. And then get out because we can't make money from you, but bring your grandpa when he has a heart attack. Bring your wife when she sprains her ankle because we can make money at that.
Well, $3,000. I already proved
That's
that.
right. So don't think that the hospitals with the monarchy not for profit are going to save the day in the community. They're running away from their responsibilities. And I am not a socialist, but Bernie Sanders, Elizabeth Warren, if you're listening, hold them accountable. If a community hospital is not for profit and they're not serving their community, should they really be not for profit? Or should they contribute to property taxes, income taxes, like the rest of us do? Hold them accountable.
Yeah.
This is not going to solve without us advocating and advocating with some very harsh words on both sides, because we need 65 senators in DC to agree with our point of view.
Maybe we should see this episode.
Yeah, I don't care if it's 50 Democrats and 15 Republicans or 40 Republicans and 25 Democrats. Could care less.
Yeah.
I do think you have to say a lot of people, they have kids, they have grandkids. You have to ask them face to face and say, would you have felt comfortable if your child did not have someone to go to when they were sick?
Yeah.
Would you have felt comfortable going to the hospital with your child when they're sick, knowing that there was no one there to care for them? Yeah. Why would that be any different for anyone else? And it's really not a political statement. It's a pragmatic statement.
Well, a pragmatic statement. We all know, and we talked about this the other day, right? If you educate your children and you raise them well, they become productive members of society somewhere around 20, some 25, some 30, some 16. And then for the next 20 or 30 years, they invest in their communities, they pay taxes, they raise other children. And that's what sustains democracy. We're shooting ourselves in the foot by not educating our kids properly, by not demanding that they can read and write by the time they leave high school, and by not demanding that they're healthy when they're 18 and are capable of joining the workforce. And again, I'm not a socialist. I'm just saying, invest in our children. It's our responsibility as a society. Do it now. Be quiet about all these other divisive issues and let's solve the problem in our faces.
Agreed.
Right?
All right. Thank you, Herb.
Sorry about my soapbox, but
At the top of the hour, I have to go save the world once again.
Aaron,
Aaron also has to save the world.
thank you
Okay.
so much for your time. The best of luck on